last week, so we're on moving forward for the fall semester. Next slide, please. So presentation will be recorded, as you know, archived on the CD2H YouTube channel. Use the Q&A button to post your question. Raise hand for the host to unmute your microphone, or post in the chat section, which people often also do. Next slide, please. So, the next month or so presentations, Rachel Wong will be talking about diabetes and COVID, and she's done a lot of great work in that space. So she'll be talking about the latest from that group. Then pregnancy domain team updates, phenotyping and pregnancy, vaccine effectiveness analysis to date in pregnancy, with a bunch of Reena Patel, Elaine Hill, Sarah Jones, and Crystal Kin. October 10th, I guess we're still looking for a presentation, but I'm sure we'll find one soon. And then October 17th, Blake Martin will talk about acute upper airway disease in children with Omicron B.1.1.5.2.9 variant. So next slide, please. Okay, so the feature presentation, Kristina Bailey will be talking about the relationship of documented alcohol use disorder or alcohol-related complications in COVID, with the conclusion that such people are more likely to be hospitalized and have a higher all-cause mortality. So Kristina, I assume you'll be sharing your screen?
Yes, let me.
Okay, and we have 6.4 million COVID positive cases. I remember it was 5.5 at the beginning of the when we ended last round. That's okay. That's quite a large database. Okay, so next slide, please. Okay, great.
All right, I will just share my screen. All right, is that looking correct?
Yeah, that looks beautiful.
All right, well, thank you for that nice introduction. I'm really pleased to be invited to present our work.
Great, well, thanks for coming.
Thanks. So a lot of you may know that alcohol is one of the most commonly used and abused drugs worldwide. When we look at spirits consumption throughout the world, you can see that there's very few countries that are unaffected by alcohol use and misuse. The number of people with alcohol use disorders worldwide continues to grow. We're currently at over 100 million people with alcohol use disorders worldwide. And when we look at alcohol use in the United States, 85% of people that are adults have reported that they have drank alcohol at some point in their lifetime. And we have 14.5 million people in the United States with alcohol use disorders. That equates to about 7% of men and 4% of women in the United States. So how is alcohol use disorder defined? One of the ways that alcohol use disorder is classically defined in research and in clinical care is by using the alcohol use disorder inventory test. identification test, sorry. And this test looks at several different components of alcohol use. The first is alcohol intake. It asks people to quantify how many drinks and how often they're drinking. It also asks questions about potential dependence on alcohol. And then it talks about experience of alcohol related harm as well. So has the person been injured as a result of their drinking? Are their family relationships being affected, and that sort of thing? So this is scored from 0, which is complete abstinence, to 40, which is the maximal response in all 10 questions. And when you score 1 to 7, there's a low risk of alcohol misuse. 8 to 14 is defined as alcohol misuse, and 15 or greater is thought to be alcohol use disorder. So I think all of us know that alcohol can be hard on our liver, but we've probably thought less about how it might affect our lungs and how our lungs function. But I do want to remind you that one of the ways that we measure alcohol concentrations is with a breath test. And that's because the alcohol, and in particular the airways, the lung is one of the most, has a very high concentration of ethanol. So this is a picture of a police officer sobriety testing and doing blood alcohol testing, not blood, breath alcohol testing on an individual with a traffic stop. So it's been known or observed for a long time that alcohol can have detrimental effects on the lung. So Benjamin Rush was one of the signers of the Declaration of Independence and was the first Surgeon General of the United States. And way back in 1785, he wrote that alcoholics are more susceptible to all manners of infections, especially those of the respiratory tract. And then Sir William Osler, who is considered the grandfather of internal medicine, also observed in 1902 that those who by excesses of alcohol have weakened their reserve power fall an easy prey to pneumonia. I love this picture of him. My desk and table looks very similar. That's why I have to blur it out on Zoom meetings. So how exactly does alcohol misuse affect the lungs? So it can affect it in a variety of ways. I have to get these pictures out of the way so I can see. First, we have altered oropharyngeal flora that changes what can be aspirated into the lung. And then while people are heavily drinking, you have a blunted cough and gag reflexes that can predispose to aspiration. There's also in the trachea, there's cilia that help move mucus and other things that have been aspirated up out of the lung, and that function is impaired by heavy alcohol use. And in addition, we also have dysfunction of the alveolar macrophages and both the airway and the alveolar epithelium. And so you have breakdowns in several layers of the lung. And we also have known for quite some time that chronic alcohol abuse predisposes people to ARDS. And you can tell that that would be something that would be very important in COVID, because ARDS was a defining factor in severe COVID. So those with a history of alcohol abuse are nearly twice as likely to develop ARDS. And once they develop ARDS, their mortality is much higher. So mortality in those with alcohol use disorders was 65% compared to 36% of those without alcohol use disorder. And when we look at bacterial pneumonia, there's a dose response curve for your relative risk of developing pneumonia based on how much you drink. So this chart shows alcohol intake in grams per day. I don't think many of us think about alcohol use in grams per day, so I've converted this to standard drinks per day. And so this side of the curve is 4 standard drinks all the way up to 24. And you can see that there's a linear relationship to your risk of developing pneumonia based on how much you drink. So based on what we know about alcohol use and the lung, we hypothesized that alcohol use disorder increases the severity and mortality of COVID-19. And I just wanted to give you a little bit of an overview of our approach to this hypothesis. We, of course, use the N3C database with level 2 data, which means that it's de-identified and date shifted. We used, for the data that I'm going to present today, release 47, which included data up until September 2021. So our statistical methods, we used univariable and multivariable logistic regression for hospitalization and inpatient death. We assessed associations between alcohol use disorder, hospitalization, and inpatient death while controlling for major risk factors. One thing that was a little bit unique about our approach was that we did use data partner robustness matrix to identify minimum reporting requirements for the data partners included in this study. This also isn't always used in N3C, but it is a technique used in other federated studies such as PCOR-NET. So to talk about that in a little bit more detail, the rationale behind site exclusion criteria is to make sure that data availability at a site level is consistent throughout the entire cohort. So we set minimum thresholds for data density in the measurement domain to increase the ability to have complete data. So if a site had limited death reporting, which we defined as being 1 standard deviation below mean reporting, or insufficient measurement reporting to calculate a BMI, if this was 1 standard deviation below mean reporting, we would exclude that site. And so by doing that, we were able to increase prior visit history by 1/6 and decrease data missingness by 1/3. So moving on to our person level inclusion and exclusion criteria, we cast a very broad net. We included anyone with a positive PCR or antigen test for SARS-CoV-2 who was 19 years or older. And we excluded people that did not have age or gender included. This was our inclusion criteria with that broad inclusion criteria in this build of the NC3 database. We had 2.85 million people with 65 data partners. Once we excluded patients with missing gender, age, and data partners who did not meet our inclusion criteria, or as well as from the pediatric hospitals, we had 1.3 million cases and 44 data partners. Once we broke that into those with no AUDs, we had 1.3 million, and we found 25,000 people with either alcohol use disorder or alcohol complications. Once we completed that analysis, we went on to look more carefully at the hospitalized study cohort, since there's better data for mortality in inpatient people. We initially did some exploratory analysis to identify variables of interest and filter out non-contributory covariates. Our final covariates included age, gender, race, BMI, comorbidities, smoking status, and alcohol use disorder or alcohol complications. So the first set of data I'm going to show you is in this entire cohort, both those that were hospitalized and were outpatients. So geographically, we had a really nice geographic distribution of this cohort. You can see that the numbers are very similar from every region. So in that cohort, we had approximately 1.3 million COVID positive patients. And those were broken down into 1.3 million with no AUD and 25,000 with alcohol use disorder. And so we defined alcohol use disorder by these concept names, with alcoholism and its concepts and alcohol-related complications. Our logic was included in the cohort if a patient is associated with at least one of the concept sets listed in the condition occurrence table prior to the COVID-19 diagnosis. So some of you may be looking at the 25,000 people out of 1 million and saying, wait, you only had 2% of people with alcohol use disorder. I thought you told me that in the United States, we expect about 7% of men to be diagnosed with alcohol use disorder and 4% of women to be diagnosed with alcohol use disorder. Well, one of the enduring issues of doing alcohol use disorder, electronic medical record data research is that this type of data isn't well represented in the medical record. And then when you add to the chaos of the pandemic and the fact that most of the data we were collecting were very early on in the pandemic, I think a lot of times collecting alcohol use data fell to the bottom of the pile. And also, you know, you have a certain amount of COVID patients that are intubated early on, and you just don't have the opportunity to get that information in their admission history. So when we look at the demographics of the entire cohort, You can see that there are some dramatic differences between certain points of the cohort. So the first thing is those with alcohol use disorders were much more likely to be male. That's very known and established in the literature. So it's not unusual that males in a COVID-19 cohort would also have more alcohol use disorder. In addition, we saw that there were a lot more current or former smokers in our AUD cohort. That's also unknown from the alcohol use disorders literature. People that tend to drink also tend to smoke heavily. For whatever reason, those two things tend to go together. One interesting thing that we found in this cohort was that the comorbidities in those with alcohol use disorder were much higher. And some of these things have been reported in the literature. You know, it's not surprising that cirrhosis would be much higher in those with alcohol use disorders compared to those without. Likewise, there's established literature that alcohol use disorder predisposes people to hypertension. But there was a number of other comorbidities that were also higher in those with alcohol use disorders, including diabetes, myocardial infarction, congestive heart failure, peripheral vascular disease, stroke, dementia, and COPD, or chronic obstructive pulmonary disease. And this is likely related to the fact that we had more smokers in that alcohol use disorder group, although there's some thought that the damage to the airway epithelium from alcohol itself may also predispose people to COPD. And then there was also more peptic ulcer disease in those with alcohol use disorders, which isn't surprising because alcohol use is a risk factor for developing ulcers. And also, not surprisingly, we saw that the alcohol use disorder group had a much higher rate of multiple comorbidities versus single comorbidities. So 38% of the group with no alcohol use disorder had multiple comorbidities, while nearly double that in those with alcohol use disorder. So moving on to our unadjusted outcomes, we found that those with alcohol use disorders were much more likely to be hospitalized than those without. Our unadjusted odds ratio was 2, and these were highly statistically significant. Likewise, in our unadjusted outcomes, death or transfer to hospice was twice as likely in those with alcohol use disorders. We went on to then adjust our odds ratio in the hospitalized individuals. And so here's our forest plot for hospitalization with AUD. We corrected for all of these, or we adjusted for all of these variables: age, sex, race, smoking, BMI, and then all of these listed comorbidities. And you can see how each of those comorbidities or components changed the odds ratio. Even when we corrected for all of these, the odds ratio for hospitalization with alcohol use disorder remained very significant, with an odds ratio of 1.51. Likewise, we corrected for our all-cause mortality. And once sorry about that. Once we corrected or adjusted for all of these same components, those with a history of alcohol use disorder still had a higher mortality or transfer to hospice with an odds ratio of 1.55. And again, this was very statistically significant. So then we went on to look at the hospitalized cohort, and the idea behind looking at those that were hospitalized was to get a better sense of mortality, since mortality data is most robust in those that die while hospitalized or transferred to hospice while hospitalized. It also gave us a chance to look at treatments that were given in the hospital. So in this cohort, we had a total of 202,000 patients. 196,000 of them did not have alcohol use disorder, and a little over 6,000 did have alcohol use disorder. And so this is the demographics of the hospitalized cohort. It's very similar to the cohort overall, in that males were much more likely to have alcohol use disorder. And smoking was also more common in our AUD cohort. I also want to point out that when we were looking at age, the mean age of those in our alcohol use disorder cohort was lower than those without. And the biggest difference seemed to be in the 50 to 64 age group, with 28% of those, 28% in that age group with no alcohol use disorder, and 39 in our alcohol use disorder cohort. While the elderly group of those over 65 was very similar, 40 versus 38%. My box kind of covered that up, sorry. Very similar to the cohort as a whole, in the hospitalized cohort, those with AUD had many more comorbidities compared to those without. This included HIV/AIDS, solid tumors, any malignancy. Of course, heavy alcohol intake is a risk factor for many different cancers, so this isn't necessarily surprising. Renal disease was higher in those with AUD. Cirrhosis, of course, was higher in those with AUD, as well as chronic pulmonary disease, stroke, peripheral vascular disease, congestive heart failure, diabetes, and hypertension. So when we looked at clinical outcomes and inpatient therapies for those that were hospitalized, you can see that acute kidney injury was more common in those with alcohol use disorder. Mechanical ventilation was similar, and death was slightly higher in those with alcohol use disorder, 13% versus 12%. For whatever reason, those with alcohol use disorder were less likely to get steroids during their hospitalization. They were more likely to get remdesivir treatment, which was a little bit surprising to me, since I would have thought that this might actually be lower in those with alcohol use disorders if especially if they had cirrhosis or elevated liver function tests. Transfusions were the same, and those with alcohol use disorders were slightly less likely to be on vasopressors. Once we adjusted our odds ratio for inpatient death or transfer to hospice, those with a history of alcohol use disorder or alcohol complications continued to have a higher odds ratio of death at 1.12. This is just another view of that same data, showing you the contributions of each of these covariates. So anytime you do electronic medical record-based research with alcohol use disorder, it becomes difficult because most of the data that's entered in relation to alcohol use disorder, if it is at all, any alcohol use history is going to be a free text variable. And it's going to be presented in a myriad of different ways. When you look at the social history, it's very common to just see documented that patients use alcohol socially. It's completely impossible to quantify how much alcohol that might be. And then when it is quantified, it's quantified in ways that are difficult to reconcile. You know, maybe they say that they drink 6 beers a day, or they drink half a liter of vodka on the weekends. It's very difficult to reconcile that sort of data. So we acknowledge that the patients that we were able to study in the N3C likely had very severe alcohol use disorder and had probably were being actively encouraged to seek help or rehab for their alcohol use disorder. I showed you data early on in relationship to pneumonia that even what some people might consider moderate alcohol use can increase the risk of pneumonia, bacterial pneumonia. We weren't able to look at that in this cohort because we didn't have either audit scores to risk stratify their alcohol use, or really any definitions of how much alcohol they were drinking at the time. One thing that we noticed as we went through our analysis was that those with alcohol use disorder were better known to the healthcare system. So they were more likely to have complete data compared to those that did not have alcohol use disorder. Another thing that we struggled with is that we were unable to determine whether ARDS was increased in those with alcohol use disorders. That was one of our initial things that we wanted to look carefully at, just because we do know that epidemiologically ARDS is more common in those with alcohol use disorders. And we weren't able to look at that carefully due to variable ways of defining ARDS in different centers. Another limiting factor is those with alcohol use disorders, not surprisingly, had a higher rate of cirrhosis. And so it's not entirely clear if cirrhosis alone may increase risk of mortality in COVID-19, or if that's related to alcohol use. So, thinking about our conclusions, those with alcohol use disorder are more likely to be hospitalized for COVID-19 and have higher all-cause mortality. It's not clear if this is simply due to alcohol intake or if this is related to comorbidities caused by heavy alcohol intake. Although once we correct or adjust for multiple comorbidities, it does look like there's a trend towards alcohol intake alone worsening COVID-19 outcomes. So further research is needed to determine whether alcohol use disorder is an independent risk factor for poor outcomes with viral pneumonias, such as COVID-19. This has already been fairly well established for bacterial pneumonia and ARDS. Given the strong association with alcohol use disorder with the need for hospitalization in COVID-19 pneumonias, clinicians should bear this in mind and try to ask more questions about alcohol use and misuse in this population. If you would like to take a closer look at this data and this work, we have recently published this work in the Journal of Alcoholism, Clinical and Experimental Research. It's the journal of the NIH section of the NIAAA, which funds alcohol research. If you'd like to look it up, the PubMed ID is 354-29004. So what are our next steps? I think we've convinced ourselves that those with alcohol use disorders have more severe COVID-19 infection. And one of the things that we're curious about is whether those with alcohol use disorder are also predisposed to the development of long COVID. Certainly a risk factor for developing long COVID is having more severe disease early on. So this is something that our team is going to continue to look at. So I just want to take a moment and thank the team that helped us do this research. My background is very much that of a basic science alcohol researcher. Prior to this project, I focused on how alcohol exposure in vitro cells affected pulmonary innate immune markers, but many people on this list took me by the hand and helped me figure out how to do a more clinical research project. And of course, the person that worked all the magic was Jared Anzalone, who's here at the University of Nebraska Medical Center. He does a fantastic job of helping lots of researchers across our university ask COVID-19 relevant questions. And I can't thank him enough and know that we definitely couldn't have done this project without him. Corey Hansen is a registered dietitian who has lots of experience with electronic medical record research as it compares to nutrition and malnutrition. One of the things that we noticed during our research was that, not surprisingly, those with alcohol use disorders tended to be more malnourished. And so we went back and looked at malnutrition as a risk factor for COVID-19 as well. Harlan Sales is a statistician that did the majority of the analysis. James Campbell helped us put together the data sets early on and helped us figure out which codes to use. Ellen Burnham is a pulmonologist and alcohol researcher at Colorado who advised us with a lot of the alcohol-related questions as well. So I'm very thankful to this team. And at that point, I will stop and see if I can answer any questions.
Okay, Kristina, great talk. Thank you. Very interesting. So we've had a question for a while from Hyojung Kan in the Q&A. Could you explain how you handle the imbalance between the AUD and non-AUD groups in the analysis, and how did you identify comorbidities or concept sets?
Great. So I'm going to ask, maybe Jared could come on and help me out with this question as well.
Say with somebody.
How we...
Oh, Jared. Okay, you're a panelist. Great. Does somebody need to unmute Jared or?
Yeah, I don't, somebody will have to. He has his hand.
Yeah, working on it, sorry.
Okay.
Great, I think you can hear me now.
Yeah,
I need a little clarification on the question about balancing. But for the concept sets, all of them were, defined using Atlas. So for the most part, that would have been, condition occurrence in OMOP. So we use SNOMED CT. We had our clinicians on the team both review all the concept sets that we used for the comorbidities and for alcohol use disorder. And then the same happened for the therapeutics that we looked at. So those either used all of the validated concept sets that N3C has produced by the community, and our clinicians reviewed them, or we produced them on our own.
Great. Well, thanks.
Yep.
So I have a question. This is a very challenging area, obviously, because as you stated many times very clearly, the reporting of alcohol use disorder is, variable and not necessarily all that well controlled. And that was actually a very interesting comment you made about how alcohol use disorder patients had more data associated with them being, better known in some sense. So I'm wondering, in terms of the methodology of controlling for multiple comorbidities, and it would seem like there are a bunch of ways of doing this, and I'm not a biostatistician, but I've seen in a number of the studies in N3C, people have used propensity matching. Is that a method that you guys have used or looked at, or do you have any, at least from the biostat perspective, any comments about, sort of ways of doing sanity checks in terms of multiple comorbidities, bad, alcohol use disorder, bad? Can you disentangle those?
And with alcohol, I think it's it's even more complicated because alcohol contributes to a lot of those comorbidities. So that was something that we spent a lot of time talking about, and I'm not sure we ever came up with the perfect answer. In the end, we just chose to adjust for the comorbidities. We did pull out cirrhosis because that seemed so directly linked to alcohol that we didn't correct for cirrhosis.
Mhm. Great. Okay, so a follow-up question from Dr. Kang. I wanted to know if you used any case control, if you used case control approach to address the imbalance between the two groups of the main factors, as well as the imbalance between the outcome groups, dead versus alive. Thank you.
We didn't do that, but that is, that's a great suggestion as we embark on looking at long COVID data. That might be an approach that we could successfully use in that data, because we haven't looked at it yet, but I suspect we're going to have a lot of the same problems in that group as we did in the hospitalized group.
Mm-hmm. Though I'd imagine with long COVID, you might be, I mean, I suppose it depends on what, thank you for your answer. What data sets you might or might not be in a position to supplement the N3C data with, but certainly a scenario, or maybe you could speak to the scenario where maybe you'd be in a position to at least sample some patients so that you actually could look at, text descriptions or NLP extracted information from text.
Yeah. Well, and I think one of the problems with alcohol research too is that people aren't always necessarily completely truthful when they do report their alcohol use. So one thing that we're thinking about trying to do with a biobank here at the University of Nebraska is to measure a biomarker of heavy alcohol use, phosphatidylethanol, and try to look at that in outcomes, because I think that would also be a cleaner measure of alcohol use.
That would make sense. So what biomarkers exist? Is there an A1C equivalent for chronic alcohol use?
Yeah, it's the phosphatidylethanol, and it will stick in the system for at least 2 weeks. So if they've had blood drawn within 2 weeks of their hospitalization, we should be able to get a sense of how heavily they use alcohol.
Wow. Oh, that's interesting. Now that's intriguing. Yeah, go ahead.
And like every biomarker, there's all kinds of discussion about how accurate it is in different comorbidities. So it will have its own set of problems, but that's something we're hoping to embark on soon.
Interesting. And then obviously you could use that potentially to calibrate some of the other data you have. Well, that's very interesting. All right. Well, it's a great talk. Other questions? Comments, thoughts? Okay, well, thanks for a really interesting presentation, and we'll give folks 10 minutes back and see you next week, if not before. Thanks.
All righty, thanks.
Bye-bye.
Thank you, Dr. Bailey.